Thank you very much. So we're now ready to kick off the last session of the day, precision treatment. We have two speakers, and I'm very happy to introduce our first speaker, Dr. Valentina Cardi. She's clinical psychologist and assistant professor at University of Padova with a very long collaborative link with the LPPN. Thank you. And yes, and she's going to talk to us about virtual reality as innovative treatment for eating disorders.
Thank you. Many thanks, Ulrike. Thanks to the team. I'm delighted to be here, and though I'm now based in Italy, it's great to be part of this stimulating team and environment still now. So many thanks. I'll be talking about the use of virtual reality in eating disorders, and I'm amazed at how the colleagues have, managed to talk about lots of studies in very little time. I'm going to talk to you about one study only, but hopefully it will give you an idea of the direction we are taking. So why using virtual reality? Not just because it's a new technology and it's very exciting. I think it holds lots of potential in mental health care, and especially in eating disorders. This is because it's very engaging and is appealing. It provides new learning opportunities in a safe environment. It enables repeated and controlled exposure to new information. So in a way, is a very good, is halfway through experimental control, but also treatment in an ecological valid environment. It can record both active and passive data, and I will show you an example of this. And potentially, it may not require therapeutic guidance, so it can be automated. And what have we used virtual reality for? Well, we have tried to use it in eating disorders because we know that in eating disorders, people are very likely to develop habits, so habitual behaviors, which become very difficult to break over time. And so virtual reality can be a tool which they can use in their own environments over time in order to learn new interactions with the environment, with the stimuli, such as food, of course, in their own time. And in particular, in the last 10 years, I've been interested in a specific characteristic of eating disorders, which is fear and avoidance of food, which are particularly salient features in anorexia nervosa. Anorexia nervosa typically is characterized by food avoidance, and refeeding is one of the main treatment goals, but it's also one of the most challenging goals, as we know. Yet there are no evidence-based psychological interventions which tell us how to reduce food anxiety and avoidance in the best way in people with anorexia nervosa. So over, as I said, the last 10 years or so, we have been using different strategies trying to encourage a more positive relationship with food in people with eating disorders and anorexia nervosa in particular. We have published a few studies where we show that, for example, patients who have had a chance to look at a brief podcast inducing positive mood or showing a motivational enhancement script, that they would reduce anxiety associated to food more than people allocated to a control condition, and also they were more prone to drink a smoothie, so they would be more prone to consume more calories compared to people allocated to a control condition. So basically, this is to show us that the use of mobile technology can be helpful in the moment to help people reducing anxiety and avoidance of food. And this was very helpful background work. Of course, at the time I developed these studies, I didn't know that many years later, this interesting framework would have been developed by Michel Krask, which is called the Inhibitory Learning Framework, which basically tells us that exposure to threatening stimuli can be enhanced, can be more effective if not only we expose people to the stimuli that they fear, but also if we use other strategies to enhance the inhibition of fear. And inducing positive affect is one of those strategies. So this is a framework. It hasn't been tested in clinical studies. So again, for us, this was a first attempt to use this framework and implement it using virtual reality. So we have developed a virtual reality environment to test inhibitory learning of food fears in anorexia nervosa. So we have developed 3 different conditions, and I must acknowledge that we have developed these conditions together with people with lived experience over more than a year. So pretty much each characteristic of these environments have been discussed with people with lived experience. So in the first condition, we have a virtual kitchen alone, and I'll show you the virtual kitchen in a second. In the second condition, people can explore the virtual kitchen together with a pink elephant. So this is a pet which is in the kitchen with the participant, and the participant can cuddle the pet, the elephant. And you can guess that the idea is, as I say, to increase the level of positive affect. In the third condition, there's the same kitchen, but this time participants spend time with an avatar, and the avatar speaks a motivational statement. And this statement, this script has been, again, co-developed with people with lived experience. I'll show you a video to give you an idea of the virtual reality environment.
When you are ready to start, enter your 4-digit ID number and press OK.
So this is the assessment part, which is also done in virtual reality.
Success. You are now logged in. How anxious do you feel right now? You will not be alone in the kitchen. In fact, you will be in the company of a friendly avatar. Use the slider to make a selection, then press OK to enter the kitchen. You are doing the best you can right now. Nobody is here to judge what you will do in the kitchen, which foods you will look at or grab. Take a few deep breaths, slow your mindset down, and think of the bigger picture. Each minute more is a minute easier. While challenging the eating disorder thoughts, remind yourself of all that you have achieved so far. The relationships you share, the passions and dreams you have. They are so important and will ultimately help you to break free of the eating disorder constraints.
Yeah, sorry, I'm stopping it there in the interest of time, but just to give you an idea, so the kitchen is the same in all 3 conditions, and what we have shown you is the condition where the avatar is present. So you have heard the script and you have seen the avatar. So this is the flow diagram of participation in the study. And you can see that we had a final sample of 145 people with anorexia nervosa, and people were recruited both in the UK and in Italy. They completed a series of questionnaires, but what I wanted to highlight is that participants were randomized to one of the 3 conditions, so they only received one of the 3. And this was a one-off exposure, so it was only on one occasion that they were exposed to the kitchen, and it lasted about 6 to 7 minutes. What's very interesting of this virtual reality headset that we have used, which is called Oculus Quest, is that it also records the number of interactions that people have with the virtual objects. So we have a measure of whether they have touched the food or cuddled the pet. and we know the frequency of the number of times people have looked at food items. So these are called kind of passive data, which people do not report to us and give us an indication of also their approach or avoidance of the stimuli. And this is just one of the findings. I would say probably the main finding is that, in a way, as we expected, anxiety related to food was lower in the PET condition compared to the other two conditions. We have interviewed all people who took part in the project, in the research, and we were particularly interested in their feedback about PET and the avatar. So these are some quotes about the PET. So the idea was that the PET would induce positive affect. In particular, what people seem to report is that they felt connected to the pet in the environment, and that was helpful, but also they didn't feel judged as they would have felt if they had seen a human being in the environment. So they don't want to be alone, and at the same time, the pet made them feel unjudged. In terms of the avatar, we had problems with developing the look of the avatar. So you have seen it's quite robotic, so it's not perfect. We need lots of kind of money to develop this in a better way. But again, it's just the start of a journey which we are continuing. And at the moment, we are testing repeated exposure to these environments, and we are comparing exposure to virtual food to a control condition, which is a relaxation environment. We are doing this over a week with patients admitted to daycare. And again, the idea is trying to find out whether repeated exposure will help people coping better with meal times in real life this time. So many thanks. Happy to take your question.
Any questions?
My co-chair, Diego Rabelo de Ponta, working at the HDP with me, is happy to take you.
Hey, thank you. I was just wondering about how, like, being alone and immersed in a virtual world mixed with what you've been hearing more generally from other speakers about the importance of social integration in the real world, especially outside of like the importance of social integration. Julia.
Yeah, absolutely. That's a very important point. I think this is just one part of the jigsaw. This is to help people coping with food fears and being able to approach food more. And of course, you know, when we did the work with the people with lived experience, one of the ideas was to have someone, you know, an avatar which might resemble a loved one. People felt that at that stage, it would have been too early to have someone who looked like someone they love. Because in a way, this is very much considered like a difficulty which not everybody's ready to share at this stage. There's a lot of shame and embarrassment around these difficulties. So this is why they like the pet, and they came up with the idea of the pet, you know, which doesn't resemble, as I say, a human being. And again, with the avatar, they weren't too sure about that. But one of my earlier ideas was, for example, to have pictures of loved ones, you know, carers. But in a way, they are very protective, you know, towards their carers. So they prefer to exercise in a safer environment by their own, on their own. So again, I think this is just the first step, and it would be great to integrate this with, you know, working with carers and trying to help them to increase social connection through virtual reality, perhaps not together with food exposure.
Thank you.
Any other questions?
Hi. I was wondering how. I didn't
have to frame this as a question, but maybe I'll get there.
I was wondering
whether
for interacting with
food in a virtual space
is
something that lots of people with anorexia do anyway as part of their illness, because it's not, I'm not saying everyone, but for a lot of people, the problem's not about approaching food and being around food, it's the actual eating of it. So, it's common for people to look at food obsessively and cook food obsessively. And so I was wondering whether this scenario might be perhaps even more applicable to an eating disorder like ARFID. Yeah, I don't know if you have any thoughts on that.
Absolutely. So one of the goals is to help people to approach food, as you say. So we will be starting a little pilot with people with ARFID. Also, what we're trying to do using virtual reality is having food as well as other objects. And the idea is not so much about approaching food, but also approaching food in an environment which feels safer and nicer. Because really the target is the negative emotions associated with food, more than food avoidance, as in not touching food, if that makes sense.
Okay, 1 second.
Thanks, Valentina.
Really interesting. I wondered whether you have any data on how this translated out into behaviour or experiences in the non-have.
Not in this study, because this was only a one-off exposure, and we were interested in mechanism more than efficacy or effectiveness. But in the case series, randomized control trial that we are running at the moment, we are measuring food anxiety before and after meals at the hospital. So we are taking that as a proxy measure of how well they do, how well these things translate into real life. Yeah.
Hi.
Last question.
Hi. Thank you so much for the presentation. It's really nice. I have a question based on the virtual reality presentation. So let's say I have a client, and the client, after the assessment, is choose like out of the 3 kitchens, which one I want to go, or how does that work? That's my first question. And the second question is about the age demographic of the study, and if you feel like the results would be different in case, for example, if there were young people in the studies compared to older people.
Yeah, absolutely. So in this first study, they could not choose. They were randomly allocated to one of the 3 conditions. In the current study, where we are doing repeated exposure, they get to choose whether they want to be exposed to one type of kitchen or the other, and they can change their preference over time. Demographics, so these were young adults who took part mostly in the first study. In this second study, we are trying to recruit people who are a little bit older, but it's a bit difficult because in our service we are seeing lots of younger people. So yeah, it will be very important to see whether the same acceptability translates to older people. Thank you.
Thank you for amazing talk.